Today we're going to be talking about the ideal positions of neonatal lines and tubes on x-rays. Stick around to the end because I'll go over some trickier x-rays to test you all and make sure you've absorbed it all. I'm Dr. Tala and I've been a neonatologist for over 15 years now, and so far it's been standard of care to use x-rays to check for proper line and tube placement. But we're in an exciting time in medicine, and in a few years, we'll probably all be using bedside ultrasounds to check placement of everything. Or even before then, maybe artificial intelligence will help us with some of these x-ray images. And for example, after one is shot, it will tell us to pull UAC out 1.5 centimeters. That was my robot voice, by the way. Or in this x-ray, the robot will tell you that the UVC is too low. But for now, this is where most of us are, using x-rays to check position and making our own decisions based on what the x-rays show. Let's start with the ideal position of endotracheal tubes. And ideal location is considered to be the mid-tracheal position. So that's halfway down the trachea between the bottom of the clavicles and the carina. The carina is where the trachea splits off into two bronchi. In this figure, the letter D represents the mid-tracheal position. You can see the carina here and the undersides of the clavicles here. So D is what you're aiming for. And here is how we look for the mid-tracheal position on an actual x-ray. So look at the base of the clavicles and notice this is right where the clavicles are closest to the vertebral column, so the lowest portion of the clavicles. Then you have to figure out where the carina is. Sometimes, for example, if the baby has bad RDS, this can be pretty easy. Other times it's harder. But here again, if you were to intubate this baby, the middle line is where you're aiming for, exactly midway between the base of the clavicles and the carina. Interestingly, the NRP, or the Neonatal Resuscitation Program, recommends that even though we're aiming for the mid-tracheal position for ET tube placement, we probably should not be using the clavicles as a landmark because the position of the clavicles really depends on the position the baby is in and how the x-ray is actually shot. Instead, they recommend that the base of the ET tube should align with T1 or T2, or the first or second thoracic vertebrae. The carina, by the way, is usually at around T3 or T4, so obviously the ET tube should be above this. So if we're intubating a baby, how deep should we insert the tube? The equation we're all used to using is weight in kilos plus 6 centimeters. So a 2-kilo baby, we would insert 2 plus 6 or 8 centimeters from the lip. But as younger babies are being intubated, we all figured out that this is often too deep for the tiny babies. This chart is from the 8th edition of NRP, and you can see that the weight plus 6 pretty much holds, but for the tiny ones, the tube is going in less than 6 centimeters. But as everyone who's ever taken care of a baby knows, sometimes we'll follow the chart or equation perfectly, and when we get the x-ray, it's still in a totally wrong position. So we really should always check placement. So let's look at the position of the ET tube on this chest x-ray. It's between T1 and T2, so exactly where the black arrow is pointing is where the optimal ET tube depth is. The tip of the tube, like we said, is located in the mid-trachea adjacent to the first or second thoracic vertebrae, like recommended by the NRP. So note here that the tube, if anything, looks like it's kind of at the level of the clavicles. So maybe initially you'd be like, this is too high, but more likely the way the x-ray was taken, the clavicles are lower than we'd expect. What about this tube? This was in a paper from Anderson et al. A 2-month-old X30-week infant presented with listlessness, apnea, and bradycardia, and so was intubated. After intubation, they were able to hear breath sounds bilaterally, and the PD cap, or the carbon dioxide detector, changed from purple to yellow. But this was the x-ray they got after intubation. And here you can see low lung volumes, and the esophagus and the stomach appears full of air, despite the fact that there's also this nasogastric tube in place. Also, you can see that the endotracheal tube is right next to the NG tube. So here, what happened was that the ET tube is not in the trachea at all, but rather in the esophagus. So not endotracheal intubation at all, but they missed the intubation. As an aside, it's great when groups publish mistakes like this so we can all learn from them. It's very selfless of them. And here again, another x-ray that someone posted for our education. Here you can see that there is a completely separate air column from where the ET tube is placed. And again, the lungs are hazy and collapsed. This all adds up to the fact that the tube is in the esophagus and not in the trachea. Obviously, we're rarely getting these x-rays, but this is just a reminder that sometimes breath sounds and carbon dioxide monitoring will trick you. But what we really want to see is an improvement in the baby's status, whether it's their heart rate or SATs. Now, let's at least talk about what happens when the ET tube is in the trachea, but not in an ideal place. In this x-ray, we see that the tip of the ET tube is projecting deep within the right mainstem bronchus. So, as an aside, if the ET tube goes too deep, it is way more likely to go down the right bronchus because it has a less acute angle than the left bronchus. So the right bronchus will go kind of off like this, whereas the left bronchus is more likely to go off like that. So here, that's exactly what happened, and it was a right mainstem intubation. As a result, the left side wasn't getting any pressure, and so we ended up with a collapse of the left side of the lung. There is complete atelectasis of the left lung with actual mediastinal shift to the left. In the lower x-ray, the endotracheal tube had been pulled back to an appropriate position between the clavicles and the carina, maybe still a little bit low, and with that you can see that the left lung actually re-expanded again. In this x-ray, the opposite thing happened. The ET tube has been placed down the left main bronchus. Again, this happens less frequently because the left bronchus goes off at a much more acute angle. So often you'd really have to go out of your way to get the tube there. But again, as you'd expect, you're not getting enough aeration to the right side, and so you do have collapse of this right upper lobe. So if anything, it's probably getting minimal air at all. So here again, we need to pull back the ET tube out a little bit. And another x-ray with the endotracheal tube too deep. So again, below the carina. Here again, this x-ray shows the ET tube with its tip projecting deep within the right mainstem bronchus. And here, there is partial atelectasis of the right upper lobe. So here, probably because of the way the ET tube was pointing and the direction the air was coming out of the tube, they were getting enough air to the left lung, as well as the right, middle, and lower lobes, but not to the upper lobes. And by the way, often when the tube is too deep, we would see a sudden increase of carbon dioxide if you got a gas. So think about ET tube placement if you ever see that on a gas, a sudden increase in the CO2. Again here, obviously we have to pull the tube back. What do you think about this x-ray? Here, the x-ray looks like the tip of the endotracheal tube is above the thoracic inlet, so above the clavicles and above T1. Clearly, the lungs are getting air in because even though there are coarse infiltrates bilaterally, the lungs, if anything, are hyperinflated. But as you all know, this baby could have an unplanned extubation, and what we used to call a self-extubation, very easily. And in certain positions, the ventilator could be pushing air down the esophagus into the stomach. We don't want either of these things at all, so this ET tube needs to be pushed in so that it's a little deeper. This is another endotracheal tube, again showing it to be slightly elevated, and also just pointing out the calculation that should be done to figure out how far it needs to be pushed in so that we ends up in the mid-tracheal point. On most computer programs, you can measure out the distance with little arrows, and it will tell you how many centimeters or millimeters or whatever it needs to be pushed in or pulled out. Honestly, sometimes this is still wrong. So when you move the tube, you should probably be getting another x-ray to recheck position. Right, let's move on to umbilical venous catheters. As you all probably know, the umbilicus venous catheter enters the umbilical vein, and the goal is you want it to end up in the inferior vena cava, just outside the border of the heart, just outside the right atrium. So what path does it take? Well, it goes up the umbilical vein, then through the ductus venosus, which, as you all know, is like the ductus arteriosus, in that it only exists in utero for blood to take a shortcut, and then it ends up in the inferior vena cava. So, as you can see from this picture, loads of things can go wrong. The catheter can veer off into the portal veins. This is especially true if the ductus venosus is taking off like a really acute angle, or the catheter could end up in the hepatic veins in the liver. Or it could randomly go down another vein and end up in completely the wrong place, like this superior mesenteric vein. Ideally, we want the catheter to be on the other side of the liver, but just outside the heart. This X-ray is perfect. Really, we want the catheter to be somewhere around T8 and T9. And again, the path of the UVC, from the umbilical vein all the way through the ductus venosus and to the IVC. So again, this is just emphasizing all the different ways that this can go wrong. My friend, Dr. Reese, taught me this mnemonic. This is really for where you want the UVC catheter to end up. At T6, or vertebral body thoracic 6, you have to fix it. T7 is heaven, T8 is great, T9 is fine, and T10, do it again. The caveat for this is you still want it outside the border of the heart and you want it outside the liver. And look at this perfect position of the UVC. And notice the way it kind of makes this bend through the liver. That's a good sign the catheter is passing through the ductus appropriately. So it's on the other side of the liver, but it's still just outside the border of the heart. What about this line placement? Well, if you just count the vertebrae, then this looks like the catheter is at T8 or T9, which should be okay. But obviously, this catheter is well within the border of the heart. And if a catheter is pushed up against the inside wall of the heart, then the fluids or TPN or whatever can seep into the pericardial space just by osmosis. So it's not like the catheter has to kind of actually poke through a hole in the wall to cause a life-threatening pericardial effusion. And that's exactly what happened here in this case report. Fluid collected in the space around the heart and caused heart failure. So that needed to be tapped. So take these lines very seriously and their position very seriously. Another misplaced UVC, and this one is pretty impressive. This is not something that you often see. It looks like the catheter has gone up through the right atrium and come out through the superior vena cava and then carried on going to the confluence of the jugular and subclavian veins. Obviously, way too deep and needs to be pulled back significantly. Okay, and another one where the UVC is too deep. And normally, if the UVC goes in too far, then usually it travels through the PFO, or the patent foramen ovale, which, as you all know, is the hole between the right and the left atrium. And then it ends up in the left atrium. This one carried on going through the left atrium, through the mitral valve, and ended up in the left ventricle. Obviously, this needs to be pulled out significantly too. And all of these UVCs have ended up in the liver. If you're still scrubbed in, then you can try to end up in the right place. And you can watch the video we made on UVCs if you want some tricks, which sometimes help. But if the line is already in and sutured, these need to come out. I'm not sure where these are, whether they're in the portal veins or the hepatic veins, but if what we're worried about is if we're administering fluids and medications into this relatively smaller vein, there's a higher chance of causing a disruption to a vein and then a cyst or an abscess in the liver. So if the UVC is in the liver, like you can see in all these pictures, in this like nice white homogeneous liver, then it needs to come out. This UVC did something super weird. It looks like it didn't make it through the ductus, but then instead of turning around and coming outside the same vessel, so kind of coming out the umbilical vein, it turned and entered into another vessel, possibly the mesenteric vein. Again, this is in the wrong position and the catheter needs to be removed. The last thing I want to mention about UVCs is that getting a lateral X-ray can really help you identify correct placement. The UVC runs superficially, and hopefully you'll see it above the margin of the liver and below the heart. You can see if it takes like a weird turn there, kind of heading backwards, maybe even into a spinal vessel or something sometimes. Check out the UAC though, which obviously is running in the aorta, and this is much more posteriorly. Many hospitals require lateral x-rays to check placement when lines are placed. Now let's talk about umbilical arterial catheters. Their path is a little weird. We thread one of the two umbilical arteries. Remember, the umbilicus has two arteries and one vein. I know I've said it a billion times. And then the catheter veers downwards until it joins the internal iliac artery, which then joins the aorta, so the catheter then goes back up again. We continue threading the UAC up the aorta until it reaches between T6 to T9. Because the UAC has to go down before it comes up again, we generally have to thread the UAC in way more centimeters, normally nearly double the distance of the UVC. This is an aside. At one point when I was in residency, we used to do this. We'd keep UACs in a low position, or at L3 to L5. The logic was that if there was a problem in the line, then we'd be more likely to see discoloration of the toes or feet with a lower line. But more data came out that showed that there are fewer complications with higher lines. And so now every institution aims for their UACs to be in a high position, or between T6 to T9. So look at this UAC, and it looks like it's at a beautiful position at about T8. So 12, 11, 10, 9, 8, right there. So this is in a great position. And a couple more things I want you to notice. You can see that the catheter goes down before it comes back up again. You can also see that the UAC is situated to the left side of the UVC, and that's always a good way of knowing most of the time which catheter is which, apart from it going down and back up again. This catheter looks like it correctly went down and then back up again and then seemed to curl around in the aorta. Obviously, this needs to be moved. Often you can pull this out and twist the catheter as you reinsert it, and you may have more luck with the catheter going in. This UAC is just too low and just needs to be pushed in a little further. It looks like here the team thought that this was the vein that they were catheterizing, because this seems to be another UAC here. But this catheter has ended up at about L2, so T12 there, L1, L2, which is probably the last place you'd want the catheter to be, because the kidney arteries come off from L2. So this would be a really good way to end up with affecting the blood flow to the kidneys. Because this is going in the right direction, this line, this catheter should be really easy to replace. So you can just, if you're still scrubbed up, then you can just thread it further up. But again, you never ever want the catheter to be at the level of L2. This is one of the most frustrating things that happens when you're threading a UAC, and that's when the catheters go down the leg. The catheter, instead of going up the aorta, the catheter goes down the gluteal arteries. There isn't really a lot you can do here. Once the catheter decides it wants to go down instead of go back up again, I really haven't had any luck in changing its mind. It needs to be pulled out, otherwise you may end up with a pretty bad clot and lose the sacral area or the leg. So if it's going down the leg, it just needs to come out. And our last x-rays on UACs, you can obviously see that this one has gone way too high. This looks like it's gone all the way up the aorta, but it hasn't threaded into the left ventricle. Instead, it's gone into one of the great vessels which comes off the aorta. Again, this has to come back. Apart from being in the wrong position, you're more likely to get spasming and a thrombosis, but also the catheter is less likely to draw back blood and less likely to give a good wave reading so that you can monitor the blood pressure. So yes, definitely pull this one back. Okay, let's go over 3 test x-rays for some self-testing. Make sure you've really absorbed this. So the first x-ray, where do we think this endotracheal tube is? Is it in the right place? Well, weirdly, it looks like the endotracheal tube has its tip projecting beneath the carina and not over either of the bronchi. So here this looks like the trachea, and then this looks like the carina here, because that's one bronchi and that's the other one. And it looks like the stomach is distended. The lateral chest x-ray shows that there's a column of air, probably the trachea, which is anterior or right in front of the endotracheal tube. So most likely this endotracheal tube is in the esophagus and not in the trachea. So another malpositioned endotracheal tube. All right, let's look at this X-ray. What do you think happened here? So let's look at the UVC first, and this definitely looks like the UVC because it's to the right of the vertebral column and it's making that little curve here as it's kind of going through the ductus venosus. But it doesn't stop. It just carries on going and going and going through the right atrium and apparently up the other side through the superior vena cava and then probably up one of the jugulars. So way, way too deep. And then what about this UAC? It looks like it's nowhere in deep enough. So you can see it goes down and then back up again, but it's sitting right here at probably T12, L1, L2, L3, so kind of the low-lying UAC positions. So what may have happened here is that whoever put these in made one of two mistakes, both of which are super easy to make and we've probably all made at some point. Maybe the vein and the artery were misidentified. So they thought that they were threading the vein, but really they were threading the artery. So that can happen especially if the vessels are really dried up. Or the calculation was done wrongly. So basically they ended up pushing the UVC much further in than the UAC. And because we said the UAC normally goes down before it goes up again, the UAC normally is the one that goes in a much further distance. In this case, you're basically going to end up with your lines because they're both really easy to correct. And our last one, what's happening here? When I first saw this X-ray, it looked like whoever was taking care of this baby was just a little excited with all the instrumentation and just pushed everything in too far. But then I realized this tube is going below the carina, which is right there. So it's probably a gavage tube and not an endotracheal tube. And probably a gavage tube, it actually looks skinnier and the stomach is not super inflated. So no reason to suspect, like all the other X-rays that I showed today, that this is actually in the esophagus wrongly. It just looks like it's a gavage tube that hasn't been pushed in far enough. Then it also looks like that both the UAC as well as the UVC are in too far. Again, it looks like the UAC has gone all the way up the aorta and into the superior vessels. And you can see that UVC is well inside the cardiac silhouette. So both of these need to come out, but they're going to be easy to pull out. That's not going to be an issue. Well, that's all we have. I hope that you all learned something today. If you did learn something, then please like this video. And also, please comment and tell us where you're watching from. If you're interested in the PDF summary of this video and really any of the other videos, then please subscribe to our neonatal newsletter and you can see all the details on the homepage. Again, thank you so much for being here.